Awesome. Hey, tribe, welcome. So glad you joined us today. I am with Cassie, and we are going to talk about ECMO and COVID. Thank you so much for joining us, Cassie. So, y'all, I just have to say that she has 7 years of experience. She's back in school for a perfusionist. So she's giving us this little bit of break time that she gets, and I'm stoked that you guys are getting to hear from her. Tons of questions came in, so we might not get them all answered, but we're going to do our best. So you have been in the CVICU for most of your career, right?
Yes, I have.
All right. And recently, right at the beginning of the pandemic, it sounds like you got into the ECMO coordinator position, right?
I did about 6 months before the pandemic started. Yep.
All right. So you have been baptized by fire into the ECMO coordination world. Wow. So I am so thankful that you've joined us. Do you have anything else that you would like to add as introduction for our talk today?
No, I just want to say thank you guys for having me, and I'm excited to answer all your questions. And then just an overview. Some of my answers are very center specific. All centers do ECMO differently. I'm from a big academic center, so we have a bigger ECMO program, so my answers might not apply to every center that does ECMO.
Yeah, very true. And as we know, as things change and new studies roll out, it takes years to cross all of the platforms and all of the centers across America. So absolutely, it's all definitely center specific. So I always like to do an icebreaker question. And today's is going to be, what is your one word or goal for this upcoming year?
My goal for this upcoming year, my one word is to survive. Just like I did in 2020, I want to survive 2021.
Amen to that. Absolutely. So when did you realize you had a passion for ECMO?
So like I said in my intro, I started on a cardiac step-down unit. I didn't even know ECMO existed. They never taught me about it in nursing school. I had never heard of it on my floor. But I was looking to move up, so I interviewed in the CVICU at a bigger hospital, and they're like, oh, we do ECMO here. And I'm like, I don't even know what ECMO is. So I got the job, and then I took my first ECMO patient with a preceptor on orientation, and I just fell in love with taking device patients and the advanced medical therapies that we can do nowadays.
So the technology and all that critical thinking really drew you in, it sounds like.
Yeah.
Awesome. Awesome. So Adele and a few others really asked, so what is ECMO and what are the differences in the ECMO process?
All right. So there are two major types of ECMO. There's VA and VV ECMO. VV is bypass of the lungs. So it drains blood out of your vena cavas and runs it through an oxygenator and dumps oxygenated blood either into your right ventricle, or if you're bypassing the right side of the heart, into the PA, so that your lungs can relax and take time to heal, whether that's from trauma, infection, whatever. Mm-hmm. Or there's VA ECMO, which stands for veno-arterial. So VV is all in the venous section. Veno-arterial is venous and arterial, and it takes blood from either the vena cavas or the right atria, runs it again through that oxygenator in the pump, and bypasses the heart and lungs, and it returns oxygenated blood to the aorta. Excuse me.
Yeah.
So we're doing the workload of the lungs or the heart and lungs for the patient. It just depends what their needs are.
Great. So Amber asked, what are your duties as an ECMO nurse versus a perfusionist?
So again, different centers do things differently, but as a bedside ECMO nurse, again, centers are different, but you're looking at your numbers every hour. You're making sure that your flows are the same. You're making sure that your oxygenation is the same. Some centers, like our center, will let the nurses look at the pump. So you're looking to make sure there's no clots in the pump. You're looking to make sure the patient's not having any hemodynamic shifts where their blood pressure is dropping into the 40s or their blood pressure is super high. Whereas the perfusionist is more of a high level. Some centers have the perfusionist sit in the unit 24/7. Some have them just round in the unit frequently. Again, it just depends. Mm-hmm. But they're responsible for anything that could go wrong with the ECMO circuit. So troubleshooting, if an oxygenator is failing, the perfusionist will change the oxygenator. They're responsible for helping the surgeon place and go on ECMO in the OR and any surgical procedure, stuff like that.
Okay, great. So I worked in the pediatric ICU for 13 years, also at a big academic center. And our bedside ECMO nurses had like an EBG machine sitting right there by them. They would run some labs periodically, but there was also a bedside nurse assigned to that patient to continue assessing and monitoring. Is that what you experienced as well?
Yeah, so we had what we called ECMO specialists or MCS nurses, and then they'd still have a bedside nurse. So each one of our ECMO specialists could sit to up to 3 pumps, where there'd be one bedside nurse per patient. So it's like each patient gets 2-to-1 nursing care plus the perfusionist and the medical team.
So a lot of resources are being taken up by every one of these ECMO patients.
Yes.
Yes.
And prior to that role, everyone was a 2-to-1 in an ECMO room.
Yeah.
So 2 nurses to 1 patient.
That's my experience. I'd never had an ECMO nurse that had several. But I mean, if I'm honest, I think we only had 1 ECMO patient ever on our unit at any given time. I don't believe that we ever had more. Oh, actually, I can recall one time we had 2 ECMO patients and we put them side by side. But I can't recall there ever that ECMO nurse being responsible for both patients, but I could be wrong. So we did have a question come in by a nurse who's not super familiar with ECMO. Kathy asked, well, why wouldn't you just put a patient on ECMO versus a ventilator? I think we've already just covered it based on the resource need, but do you have anything to add?
It depends on the situation. Every patient is patient specific. So resources is a huge thing. We all know there's a nursing staffing shortage, but also, like you said, the amount of resources it takes. But we also take comorbidities into factors. If a patient can be anticoagulated, BMI plays a factor. It just depends. Some patients are not good ECMO candidates, and ECMO would actually be causing more harm than good.
So that's actually our next question. We're moving into like the patient side of things and the inclusion versus exclusion factors that determine whether a patient's a good candidate for ECMO. Do you want to just briefly tell us what that looks like in your role, how you guys go about deciding?
Yep. So for every patient, we have a multidisciplinary phone call where we have a bunch of different doctors on the phone. We have the CVICU charge nurse, perfusion, the surgeon, heart failure, pulmonologist if it's a lung problem. And we all discuss the patient as a group and make the best decision for the patient. But some factors we look at are age. So usually 70 to 75 is our cutoff unless they're a great candidate. If there's any contraindications to anticoagulation, because these patients do need to go on heparin or some sort of anticoagulation so you don't clot off your pump. BMI is a factor. If your BMI is too large, you're not going to be able to get adequate flow to treat the patient and to oxygenate for them and meet their needs. Significant comorbidities, or just like if the risk is worth the benefit. So if they're a trauma patient, if they're having a lot of bleeding, they might not be a good candidate. And then we do look at vent time. So if someone's been intubated, usually we say more than 7 days, but sometimes if they're a good candidate, we'll do longer. We do make exceptions. But if someone's been on a ventilator for a long time, normally they're not a good candidate because then they're hard to get off.
And that kind of depends on age too, right? Because the younger kiddos, that 7-day window is quite a bit more wiggly.
Yeah, definitely. I work with the adult population. So having a kid who's ventilated or a baby who's ventilated for 7 days is way different than like a 60-year-old who's been ventilated for 7 days.
Yeah, and we didn't mention this, and I do want to mention it here just because I feel like it adds a lot more clarity, that ECMO is a passive flow. So as the heart adds a pulse, your ECMO machine doesn't do that. Can you just talk a little bit about why that matters in the patient's care and why that affects the way the efficacy of the flow?
For the ECMO pump, you mean?
Yeah, versus like the way your heart actually works in a pump machine as a pump itself, maybe.
Sure. I think if I'm understanding you correctly, so like for a patient on VA ECMO where we're bypassing their heart and the lungs, again, this is meant to rest the heart. So ECMO is doing all of the work. So your heartbeat is through a machine that's a motor that's spinning. So for those of you who are in ICU or understand what an art line is, normally you have pulsatility from systole and diastole on ECMO unless your native heart is recovering and kicking in, you're not going to see that. So you're just going to look for mean arterial pressures, and your art line might be a flat line, and you might just have a pressure of 60/60 with a map of 60, and that's okay. So that really does affect, like Chelsea said, how you treat the patient.
Karen asked using gravity, right? Karen, I think what you're asking is that the pump is using gravity, and it's not. If that's what you're asking, please clarify if we're not understanding you. But no, the pump is not using gravity. You can elaborate on that, Cassie, if you'd like.
There are a couple different types of ECMO pumps. So my center uses two main ones, CentraMag and CardioHelp. CentraMag uses like a impeller. It's a magnetic impeller. So a magnet holds it in, and then we set the motor to a certain RPMs to achieve the flow we want. So based on the patient's BSA, if we think they need 5 liters of flow a minute for their cardiac output, we'll set the motor to a revolutions per minute to meet a 5 liter per minute cardiac output for the patient.
Yeah. So Karen, if that answered your question, great. If not, please elaborate. So let's see. Where are we? Christina, she asked how you decide the reversibility of the disease process.
That's hard to do, and I would say that's more of a doctor than a nurse doing that, but we usually look at how far into the disease they are. So using COVID for an example, if we have a center, an outside center, because we get a lot of outside referrals from smaller centers call us, and they call us with a patient who's been COVID positive for a month on a vent and paralyzed and sedated for 3 weeks, that patient's probably not going to get better with ECMO. Now, if we have someone who calls us from a smaller center and they're like, patient came in yesterday, declined overnight, they just got intubated, not doing good, that is a patient very early on in the process that we think that we can help and hopefully reverse the disease process.
Yeah, something that New Mexico sees a lot, the state where I'm originally from, Hantavirus was something that was really commonly, we would see a lot of ECMO patients using for the treatment of hantavirus, because it's a short-lived disease, and we know that if we can rest their heart and lungs, most likely they will recover. They had great recovery rates with hantavirus, but just knowing that their disease process is indeed curable, right?
Yeah, but going off the reversibility thing, that just made me think of something else to speak to. Sometimes for patients who are waiting for lung transplants, when they're reaching the point of intubation, so that we can continue to rehab them and not have them lay and, de-rehab in a bed, we will proactively place them on ECMO. Sometimes that moves them up higher on the transplant list. And then we try to get them extubated right away so we can keep them up, walking through the unit, keep them eating, keep their nutrition status up so that they're going into transplant looking the best that they can. So sometimes we do use ECMO as a bridge to a heart or a lung transplant as well.
And so those patients, we've done one other Q&A specifically about walking on ECMO. So those patients that you're talking about, you're getting them up ambulating while on ECMO, right?
We try to walk all of our ECMO patients. If they're stable, they're doing some sort of therapy. It helps with their recovery process, and it's so good for their lungs, even our COVID patients. So we won't walk them in the hall, but we'll do therapy in their room with them.
That's great. Yeah, the effects of sedation and the long-term issues that we're learning about with our increased sedation use is so eye-opening, isn't it?
Mm-hmm.
All right. So Megan asked, how can you tell that the ECMO is working?
So it's, again, patient specific, but overall, I would say if we're able to wean the patient's ventilator, then, or even extubate them, because we want to make sure that they're to a point where their lungs are doing something on their own. We would never wean the ECMO before that, or we personally, my center does not wean the ECMO before the ventilator. So we try to get them either to the lowest ventilator settings, or we try to extubate. Most people, we are strong in early extubation. And if we're able to do that and then start weaning down on the ECMO, that's one way we prove for their lungs. And then if it's cardiac stuff that we're worried about, as they get better, like I was talking about with the art line, you'll slowly start to see an increase in pulsatility. You'll come off vasoactive medications. And then we'll do what's called a ramp study, where we'll have an echo tech come in the room and we'll turn down their flows so we can see if their heart takes over and does more by themselves. And then we look at the results of the ECMO or echo to see if they're progressing and ready to come off.
So that answers Heather and Megan's next question about the readiness for a patient to be removed from ECMO. So perfect. I cannot fathom how this next question would ever even play out, but maybe you have experienced this. I really hope not. Times are stressful and staffing is ridiculously tight in some institutions. Julie asked, let's pretend that the nurse who relieves you has never cared for an ECMO patient. What are the priority assessments and what are the top 3 patient safety concerns? What do you absolutely need to know?
Okay, like you said, this would probably never happen. Our boss would pick up extra over letting someone who's not trained in ECMO take our patient, or our charge nurse would not be patient free, or we would figure something else out because there's so much training and stuff that goes in to ECMO. If for some reason this ever happened to anyone, I would say use your resources and use your voice. If you're stuck in an ECMO room, there's obviously people around you that have at least taken ECMO, because it wouldn't be the whole unit that wouldn't be trained. So use your resources around you, ask for help, ask someone to go into the room. What is this? Can you tell me what I'm supposed to be looking for? Something doesn't feel right. Making sure to communicate right away. Hey, I've never taken an ECMO patient. Like, those are all huge things. Use your perfusionist as your best friend. Call them. They can do education with you too. Hey, I don't really feel comfortable. Could you hang closer to my room for a while? Any communication in that case would be key, and utilizing your resources there. If you're ever in that situation, there should hopefully be someone that would be more than willing to help and talk you through things.
So I'll just speak from the bedside side of things. You're going to do your assessment just like you do on any other patient. It's just going to sound a little different. And you're going to assess pupils and really listen, because it sounds different when a clot starts brewing in the machine. You can hear the difference. If you're listening every hour or so, you're going to hear the difference. And then you can tell your ECMO pump specialist, like, hey, something sounds a little different. And most often they're going to be able to see something changing on their pump that says, oh, yep, I see why something sounds different. You're just going to assess them like you do any other patient. It's just going to sound very differently. So, and pupil checks, check your pupils.
Yep.
Obviously.
Yep, because these patients are on anticoagulation, so you're always worried about a stroke.
Right. So make sure your pupils are the same, however they start out, make sure they're consistent. Yeah.
Yep.
But in my institution, we kept them paralyzed and very heavily sedated. Granted, I was in the PICU, so pediatrics, you can't tell them, hey, don't pull this kid.
No, yeah, right.
Yeah, you will bleed out and die if you do that. You can't really communicate that with them effectively. So sedation is probably the best, safest thing for them. I can't think of anything else to add to that in terms of patient safety and assessment. Can you think of anything?
Anytime you feel like something would maybe be wrong, just follow your gut. Even if you're wrong, it's better to be wrong and be safe than to not speak up at all, because chances are you're probably right. That goes with any part of nursing, not just ECMO.
Absolutely. Anything. Absolutely. I agree. Okay. So we're moving into COVID specific questions now. How are your teams deciding risks versus benefits specifically regarding COVID patients?
So we're taking a lot of factors into play. Resources and staffing are a big issue with the second wave. So we always make sure we're including, our management and the CVICU nurse, charge nurses. Do we have staff to take another ECMO patient? Yeah. And then the other big thing for these patients is intubation time, length of intubation. If they're calling us after they've been intubated for 2 weeks with resources already strapped, normally they're not a great candidate.
Well, I think this next question really applies to that. Are you seeing any increase in success of ECMO use with early use in these COVID patients versus last ditch effort?
For the COVID patients, we try to always do early. And in our center, we've been really good about trying to actually put ECMO in before they're even intubated. So we've tried to stress that point, call us before they're to the point of intubation, because then we'll place them on ECMO and try to extubate them right away. I feel like it's hit or miss, though. This disease is so unknown. Our center specifically has had a better mortality rate than the average worldwide. I can't speak to if I think it's too early to speak to if that's because we're trying an earlier approach. But overall, I think the patients that we've placed on earlier versus waiting till the 7-day they've been intubated mark have done better.
Yeah, that's great input. That answers Sarah's question perfectly as well. So Elise asked, are there any comorbidities that specifically are ruled out in terms of COVID patients, specifically a non-ECMO candidate in this realm?
The biggest one, I would say, if there's any contraindications to anticoagulation, that would automatically make you.
Right.
And again, this is center specific, but we try to keep it to single organ failure. So
okay.
Again, we do make exceptions to the rule, but if a patient's to the point where they're in multi-system organ failure, where they now have heart failure from the COVID and they're on continuous dialysis from the COVID, normally those aren't the best candidates, in our opinion, to put on.
Yeah. So Mia asked, what are your COVID ECMO survival rates, which you pretty much covered, but do you know the survival rates in other states? And that she had been working with these patients in her hospital, and she's curious how this treatment is across the nation, if you know of any comparative studies in other institutions.
It's fluctuated up and down. I talked to someone that I worked with this morning, and she thought our rate was around 40%. Last I looked, I think it's worldwide, though, was around 50%.
Okay.
A good resource for that is also.org. I don't think you need to be a member to look up COVID statistics, and it has a really good breakdown. Also is the Extracorporeal Life Support Organization. So centers that are members, like my center, we input all of our data, our mortality, any complications, and they have a really good COVID dashboard where you can see like the age ranges of people going on ECMO, survival rates, any comorbidities, and you can see a breakdown. I don't think it's broken down by state, though.
That's really interesting. I'll definitely put that in the show notes so that you guys can access that. That's really interesting. Thanks for sharing. So we don't have questions rolling through about COVID. Nope, we don't. So we'll just go on to the next question. What do you feel like the top 3 challenges are of ECMO as a whole?
Ooh, that's a hard one. ECMO as a whole, I would say these patients, some of them are in our unit for a very long time. So even though you try not to get attached to your patients, you do. So there's an emotional aspect of it. Mm-hmm. We had someone who was in our unit for almost a year. So losing patients that you see day in and day out and become like family is hard. And ECMO is a Hail Mary effort. Even if we try to institute it early, it's not guaranteed success. So I would say that's the biggest struggle, is the emotional side of it. For our unit, it's probably just the resources, especially during COVID. So if you have nurses out with COVID, you're already short-staffed, and these are critically ill, sick patients that need multiple people. I would say those are probably the 2 biggest ones.
Okay. Brandy and Julie both asked, are you okay? There's so much going on, so much death, and they just want to check on you.
That is very kind. I think I would answer for most nurses in general right now, just not ECMO nurses, and say that none of us are ever going to be the same after this, that we've lost people that we should never have lost due to this virus. So I'm sure I will be okay. Right now, it's hard to answer that question, but I appreciate the sentiment.
Yeah, for sure. Brandy asked how you decompress.
Talking about it to my other coworkers, I guess, is probably the best way, because they've all been there. Our unit is very good. When we have someone that's been in our unit for a while, our CNS will set up like a, I don't remember what she calls them, but a debrief where we have a chaplain, trauma psych comes, and we can all just talk about like any good memories we had with the patients or what we think went wrong, and we can just cry or laugh. And I feel like those help too, but really just talking to my coworkers who've been there helps a lot.
I really enjoyed those decompressing moments where you could go through the patients and what went good and what went bad and what was funny, and kept those memories alive, especially like the one that's been in your unit for a year. Like, you become family to that patient, especially visitor restrictions. You are all they have. And whether they're on ECMO or not on ECMO, or they're living in your unit with unusual circumstances, as nurses, we do get attached. And I feel like that's the human side that you never want to let go of. You never want to allow yourself not to get attached, even though sometimes we have to do that for coping. I feel like it's really healthy for us to get attached and love on these patients. That's what we're there for. All right. So let's see. Is there anything specific that you feel like makes a nurse successful in this area?
Critical thinking skills are very important. Obviously, these are very, very sick patients. So making sure to continually work on critical thinking skills. The other one, like I said to another question, is you have to be able to communicate. You can't be afraid to trust your instincts or just go to the doctor and say, listen, I don't know what's wrong, but something's not right, and I need you to come check on my patient. And they will. And then most of the time, you're right. So I would say critical thinking skills and being comfortable with communicating and being a part of a team. Teamwork with these patients is critical. You cannot do everything by yourself.
Yes, absolutely. What do you love most about ECMO?
I love the people that we save that we never would have gotten the chance to save without it. So while we've had some really sad losses, we've also had some really great wins.
That's awesome.
And there are patients that we've had that I still talk to them and their families, and seeing them doing well after the fact when they might not have had the chance if we wouldn't have placed them on ECMO. That's my favorite part, definitely.
Yeah, that's amazing. You know, there's nurses that are super interested in ECMO. And while this isn't a great place for a brand new grad to hop in and be a part of it, where would you suggest that those new grads that are really interested in ECMO and that critical thinking, where would you suggest they start to get a real great exposure to ECMO?
All right, that is a great question. I think it depends on what kind of person you are. I personally could have never thrived as a new grad in the ICU. But some people can. So if you feel comfortable jumping right into the ICU, then if you want ECMO exposure, I think trying to start in a CVICU, or it depends on centers, but I think some centers do their ECMO in the medical ICU. So starting off in an ICU that has exposure to ECMO, you might not take an ECMO patient for a year just learning how to be an ICU and critical care nurse, but you'll get exposure. You'll be around and be able to help the nurses in those rooms hang blood, give medications, just get that kind of exposure. Right. I also think it's okay, like for my example, to start in a step-down unit, get any cardiac experience you can if that's something that you're really interested in. Learn the medications, learn about heart failure, and then after you have a year or two of that experience, then try to go to an ICU. It just depends on what kind of nurse you are and your comfort level.
I love that. And yeah, different centers do ECMO in different places. Some put all their ECMO patients in one specific unit. Others just go unit to unit and have their ECMO team all spread out. It really just depends. It sounds like in your institution, if they're having one ECMO specialist to 3 patients, you guys kind of have to cluster them together. And that's awesome too. Just as a new grad, if that's something you're interested in, do your research, talk to HR, figure out where your ECMO patients are housed, and shoot for the stars. Get in there and get your feet wet. That's awesome.
Definitely.
I like that. Yeah. So what do you love most about, oh, you already told me that, sorry. What are you looking forward to most in your career as a nurse?
I've seen so much change in the past almost 8 years of being a nurse and seeing where everything goes. I didn't know a total artificial heart was a thing. I've taken care of total artificial heart patients, just continuing to see the advances that medical technology can make. ECMO, our ECMO center, when I first started off doing 20 cases a year, and now we do almost 100. So it's just amazing, just continuing to see the changes that we will make and the advancements we can make in the lives we can save.
That's amazing. That's so cool. All right. So if everyone listening just takes one thing away from our discussion today, what would it be?
Oh, that is a hard one. Honestly, that I would say, if you're interested in something, whether that be ECMO, whether that be you really like trauma patients and you want to work in a level 1 trauma ED, I can tell you as a new grad, I didn't even know what ECMO is. And then within 7 years, I became an ECMO coordinator, and now I'm in perfusion school. So not necessarily ECMO related, but follow your dreams. Anything is possible, and don't shortchange yourself, even if it takes you a couple years to get there. Follow your passion. Everyone has different passions.
Absolutely. And our career has limitless possibilities and opportunities.
Very true.
It's amazing. Well, Cassie, I know you have studying to do while you're on your break for school. So thank you so much for joining us. Tribe, thank you so much for being here. Continue to empower each other, learn together, and laugh together, and support one another. Never stop learning, guys. Have a great day.
Thank you, guys.
Thank you, Cassie.